Afternoon and welcome to our Autism for First Responders webinar. I'll be your presenter, Josh Dugell. Take us about an hour to get done with this. Whenever you start the webinar, make sure that you're opening up on your individual device, and then after you're done, you'll be issued a quiz and a survey to complete. And then following that, it's not automatic, but several days later, you will get a PDF CEU certificate. So I call this the Autism and EMS lecture. So the 411 on autism and 911. So like I said, I'm Josh. I'm the trauma program manager here at Cardinal Glennon Children's Hospital. I used to do quite a bit with our EMS outreach team and developed this lecture at pretty large amount of requests that came for these because we realized that there just wasn't a ton of education out there for kids on the spectrum and how we as first responders needed to interact with them. So I'm hoping you're able to get some good information from this today. There's no conflict of interest. I have no financial associations to report. Everything's either going to be credited or public domain whenever we talk about images and video. So we are going to define what autism is. We're going to see how it relates to us as first responders. We're going to talk about how we identify folks on the spectrum. We're also going to discuss some interventions, some things that you may do, also what you see the families be doing, talk about some safety issues, and then overall just how to make this call positive for all of us involved. So of course we got to start this off with a story. So the reason why I give this education and such a big advocate for it is because my son was born at 35 weeks. I thought everything was just awesome. I was a new paramedic. My wife was a new nurse. I didn't really understand that there were tons of milestones that were slipping by. I was completely clueless. And so I didn't learn what I really needed to know until several years later. So the first clues, of course, we had is why in the world is our kid not walking by 17 months? And why did he not talk until age 3? He had some communication, but it was really very limited, and he could talk to his mom and communicate his needs, but he never really spoke those normal words that you hear young children say, no mom, no dad, nothing like that. And then all of a sudden he started talking in full sentences at age 3. Our pediatrician just always says, he's just a boy. Boys take a longer time to do things. But my wife just really wasn't happy with that, of course. So she did not take it lightly. She started to do tons of education on herself, reading everything she possibly could, and then we were finally able to get him a diagnosis. So the red flags of autism are things that your pediatrician should be looking for, right? So whenever you go in for those well child visits, these are the things they should be scanning them for. And if they see more than a couple of them, they should really refer that child in for some more testing. So we talk about lack of an appropriate eye gaze and realize that we learn absolutely everything we know about being human from interacting with our caregivers. And if you don't look them in the eye and make that good eye contact, you miss out on all those early fundamental communication strategies. We also know that they usually won't show any warm, joyful expressions. They have a flat affect. They don't really share their interests. So a young child will usually see something that interests them and they want everybody to know about it. These kids traditionally won't. They may not even respond to their name. So early on we learn our name, and if someone says it, we turn around and look for who wants our attention. These kids just don't. And we're going to talk later on about elopement and how hard it is to find a child who doesn't know their name. We're going to see how we really need to act fast in order to have positive outcomes with those elopement calls. We don't use gestures whenever we see these kids. Again, poor communication. And then have you ever wondered why they ask for your child to stand on one foot, skip, hop, do all those like little play activities? What they're trying to find out is if your kid has a lack of coordination of body movements. So they call it body proprioception, just knowing where your body is in space. Really helps you, be safe and actually, act like a normal, neurotypical person whenever you do your physical movements. And so anytime they find a patient that has that poor body proprioception, that's also going to be a giant red flag for us. Of course, if you have really poor verbal communication, there's a good strong chance that your nonverbal communication, both expressing and receiving, are going to be limited. Having unusual speech patterns and tones is also very, very common. So we know that there's a normal cadence to speech. We understand how our voice changes inflection whenever we ask questions, and we just don't see this with these children. And then, of course, we're going to talk about the repetitive behaviors and movements, that stemming behavior that really is classic to anybody on the autism spectrum. So how in the world do they diagnose it? Of course, there's no blood test, no imaging test. It's all done through observation. So literally what they'll do is take the child and put them in a room with someone who's going to play with them. They know that neurotypical children should play in a certain manner over and over again. And they're going to watch them through a one-way mirror and watch that child and see just how they react to those normal play circumstances. And then they're going to score them on something called the ADOS, so that Autism Diagnostic Observation Schedule. And it's going to be a point system. They're also going to ask questions of the parent. If the child's in a school setting, they're also going to get feedback and questionnaires from the teachers as well. And all that stuff goes together to give us a score. And if you're above or below a certain number, that gives us a strong indication whether or not you're on the autism spectrum. So what is it? Of course, we know it's a neurologically based developmental disability, and it really affects people's communication, decision-making, and social skills. And if you can think, anybody who has a history in emergency medicine, whether in the hospital or on an ambulance, we know that people that don't communicate well, make poor decisions, and don't have socially appropriate skills, they end up being our patients. We see them quite often. The latest stuff from the CDC, and that's been about for the last 5 or 6 years, has said that, you know what, we're still at 1 in 59 kids have some sort of autism spectrum traits. Whenever I first started giving this lecture, I would go out and I would have people say, you know, I appreciate you coming out, but we really don't have kids on the spectrum that live in our area. But what we know is that this is one of those conditions where there's no social or economic boundaries. So yes, they are there, you just may not see them. Certain communities, and I'm sure you guys know certain parents who, if their child has a disease, a disorder, especially something like autism, they want everybody to know about it because they want to get every possible great interaction for that kid and tie them up with tons of resources. We also know, you know, based upon, you know, your race, your religion, your ethnicity, you may see something like a developmental disorder as a punishment. And so you may not tell people as often as other people in other ethnic groups. So yes, those kids are there at the exact same rates. They just may not be as known to you as others. And then, of course, we know that there's no known cause or cure for this. I think that's what spurred a lot of the measles outbreaks that we're currently seeing in New York City, is because of a fear mongering that came from Dr. Andrew Wakefield back in the 1990s, talking about autism and vaccines. Everything's proven that they're not correlated, but we're still talking about it. And, you know, as of 2019, we still don't know exactly what causes it. And there are some things that makes it better, but still definitely not a cure. We do know that autism is a spectrum disorder, which I think is actually probably a really good thing that we've done that, because we used to have several very defined categories. And I want to talk about those for a moment, because parents are still going to describe their child in one of those categories, because it does really kind of describe them and it gives them their identity. So we talk about classic autism. So classic autism is going to be that child that's typically going to have lower functioning. They're going to have issues maybe with what we call in the nursing world activities of daily living, where they're going to have issues just feeding and bathing and caring for themselves. They're also going to have the least amount of communication. We also have kids that have Asperger's syndrome, and that's actually where my kid sits. They used to call them the little professors, because they would usually have either a normal or a high level IQ, but they have lots and lots of social issues. So needing some extra support for those things. And then sensory issues transcend all these spectrum diagnoses. And we're going to talk more about sensory issues in just a little bit. Others that we may see are things like Rett syndrome, which looks a whole lot like classic autism, but it's one of those few disorders that only affects girls. So we know that it's related to some genetic chromosomes, right? So if you hear a parent say, my daughter has Rett syndrome, they may not identify them as someone on the autism spectrum, but we can think of it as, oh yes, I've heard of that before. We're going to call this classic autism for our thinking and how we're going to approach that patient. And then, of course, we had a catch-all, because every disease has to have a catch-all to say we don't really know for sure. And that's pervasive developmental disability not otherwise specified. It's saying this person has some traits in a lot of different categories in the autism spectrum, and we really can't give them a defined diagnosis, but we think they're on the spectrum. But what they've done with the latest DSM book, the DSM-4, they've said, you know what, instead of categorizing them, we're just going to say you're on a spectrum. You're somewhere within that colorful world of the autism community. I think it's actually good that we call it a spectrum now, because now we know those kids are able to get some services. Insurance companies historically would maybe offer services for one type of autism and maybe not another. And so by now saying you're either just on or off the spectrum, we're able to get some services early to those kids, and that really makes the biggest difference. What you guys really need to know is that just because that person is on the spectrum, they immediately are now 7 times more likely to come in contact with you. We think about, you know, the average calls that we run. There's just not a ton of primary care physicians out there. People don't have really good access to resources. So what do they do if they don't have access to resources? They use the emergency system. Now we talk about this community and the sheer desert of pediatric mental health that is out there. We don't see a lot of pediatric psychologists or psychiatrists. And so these parents really don't have anybody to go to. And so you become that last resort. They'd really rather avoid EMS in the emergency room, but sometimes there just are no other providers. And so they come more in contact with you guys. And then also in that earlier slide, we said poor communication, poor decision making, and poor social skills. Those people end up on your radar as well. I really like this quote from Mr. Dennis DeBow. He talks about autism and how it relates to public safety, especially law enforcement officers. But I love it. It says people with autism are prisoners of their sensory systems. They most times have no control over a response such as touch, taste, or smell. And something as simple as a strong perfume or a fluorescent light, while annoying for most of us, will cause a system overload for them with a wide range of results. And so if we can think about that this comes down to a sensory issue a lot of the time, it will definitely prepare us for those interactions going forward. So how in the world do we identify these folks? We know that people on the autism spectrum, they look normal. There's no defining physical traits of a person on the spectrum. And so we know that if you come in contact with a patient that maybe is in a wheelchair, you have a child with Down syndrome, it makes you think, hey, I need to alter my approach a little bit because I understand this person may possibly have a disability. But if you have no physical traits, we have to use some other clues to help us start down that path of knowing how to alter our presentation. One of the biggest things is appearing to be deaf and having poor eye contact. We talked earlier that these kids just don't make eye contact with their parents and caregivers, and so they're probably not going to make eye contact with you as a stranger. And then we know routines are huge for this population too. So if you have a routine and all of a sudden your routine gets broken, you're going to maybe be defiant, belligerent, and stubborn. You know, we said poor social skills a moment ago, and this translates directly over to that. So especially whenever I talk to my law enforcement friends, I like to remind them, be cognizant of the person standing in front of you. Yes, they may be defiant, belligerent, and stubborn. Are they doing it because they're a jerk? Are they intoxicated? Or have you picked up on a couple of other clues and maybe this person has a medical issue that's causing them to present that way? And then I think this is the easiest one to do from across the room. So being dressed out of season. We've all seen those kids walking down the street, especially those teenagers that probably don't have really good body hygiene, and they've decided to wear gym shorts in the middle of winter. They may be doing it because they're lazy and don't want to do laundry, or it's cool looking. But You've also probably seen those kids and those adults who wear clothes that you would be like, why in the world is somebody wearing a heavy coat in summer, or why are they wearing flip-flops in the wintertime? These kids and these adults are going to dress to make them feel comfortable, because I know you guys have all probably have a favorite pair of clothing that whenever you put it on, it just makes you feel good to put on. And if you have to wear something that you're not used to, you just don't feel comfortable. So this group is definitely going to dress to make them feel comfortable, and they're not worried about the temperature, and they're definitely not worried about style. So if you see that out of season dress, that might be your first red flag or clue. This person might be on the autism spectrum. And then of course we're going to talk about repetitive behaviors in just a little bit and what that looks like. So we talked earlier, we said avoid eye contact. They're not going to be using gestures. They're going to have trouble expressing needs and even simple basic physiologic needs. There was a great story that came from one of the fire crews that I did this on, where a local school bus showed up at the fire station. They had a little girl there on the autism spectrum that was having a meltdown. The bus driver didn't know what to do. So they pulled up and talked to the firemen at the firehouse, because that's who fixes problems, right? They got her off the bus. They were trying to talk to her, and they just kind of picked up a little bit of her body language that it looked like she needed to go to the bathroom. They showed her where the bathroom was. She went to the bathroom, and guess what? Crisis averted. So this entire thing came down to a child who just needed to pee, and she couldn't give you the words to say that she needed to use the bathroom. So use your thinking cap, try to pick up on that body language, and maybe that will be the only thing you need to make this emergency go away. Inappropriate responses to stimuli, and especially those that you don't know are coming. The best way I can relate this is that I took my kid to the botanical garden. We went there, he needed to use the bathroom, so we're up there washing our hands, and there's a gentleman next to us washing his hands as well. And the guy got done, and he went over and triggered the electric hand dryer, and as soon as that loud dryer came on, my son took his hands and covered his ears and just stood there and kind of froze. The guy got done, he went away, and then my son finished washing his hands, and then he went over and used the exact same hand dryer, and everything was completely fine. What was the difference there? So the difference was he knew that that stimuli was going to come. He had a couple of seconds to prepare himself, and so it wasn't a big deal. But whenever it caught him off guard, it definitely completely shut him down. So think about the things that we take for granted in an ambulance. Like if you put it in reverse, it beeps. I bet they've never been in a car that beeps whenever it goes into reverse. Also, if you happen to be using any of your monitoring equipment, it has lots of different sounds, lots of different smells, lots of things that you take for granted, but if you could pre-game that child a couple of moments before, it may make all the difference in the world. They like to be by themselves. So, we're going to talk in a little bit about repetitive behaviors and some stemming activities. We know that if you do something like you're always clearing your throat, or you're tapping your hands or moving around, you know what, your mom may say, hey, can you knock that stuff off? But guess what, if you're by yourself, nobody's going to tell you that you can't stem in the way that makes you feel better and do that repetitive behavior. So being by themselves is going to be preferable a lot of the time. And we know sameness and routines are huge. So a lot of our kids like to eat the same thing over and over every day. They like to get up and go to school at the exact same time. They know that things happen in a certain order. And so we need to use that to our advantage. There was another great little story talking about a girl who came to the emergency room who was going to get a 72-hour behavioral health hold because they couldn't get her to take her medicine. And then one of the nurses happened to ask the caregiver, hey, Mom, how does she usually take her medicine at home? And they took a couple of minutes to describe that she would take her medicine after dinner, and they always drank out of this cup with a curly-Q straw. Well, they found one of those curly-Q crazy straws. Guess what? She took her medicine 10 minutes later, and she went home, and they avoided that entire 72-hour hold. And so use those routines to your benefit. And then, of course, difficulty interacting with others. All these things that we've talked about definitely adds up to that one as well. We also see that a lot of times they will avoid touch, especially that just normal touch that we do day to day. So those handshakes, those hugs, touching somebody on the shoulder, they may not like that. But we do see a lot of these kids liking heavy, deep pressure. And that's why you'll see, as part of the autism community, you'll see them wear weighted vests, or they'll use weighted blankets to put on their lap. It really seems to calm their sensory system. It kind of overwhelms it, and it actually feels good to them. But we find that some of these kids actually may try to seek out this heavy, deep pressure in unsafe ways. So these kids have maybe had prior interactions with law enforcement, and they know that if they say something really rude or they kick that cop in the shin, they might get tackled by a 200-pound law enforcement officer. And guess what? If you're looking for a heavy, deep pressure, being tackled by a 200-pound cop may be the way that you get that heavy, deep pressure, but we understand that's not the safest way to get it done. So keep that in mind. We're going to see some examples in a video a little bit later for food for thought too. Being insensitive to pain. So sensory systems that don't quite work right lead you to maybe having some pain receptors that are not doing the neurotypical thing. So we're going to talk about medical issues in just a little while. But we say, you know what, if it looks like it would hurt and a neurotypical child would be complaining of a fracture or dislocated arm, go ahead and treat your patient with pain control too. No fear of danger. So this is one of the biggest things that this community struggles with, is they really don't understand danger. And so that's why they will walk out into traffic. They will go back into a burning building. And there's actually some really, I would say, good case studies, but unfortunate case studies that show there's a direct correlation between children and on the autism spectrum getting struck at train crossings compared to neurotypical kids. There is no fear of danger, and a lot of these kids, if you take a look at it, there's even another study that talks about the correlation between Thomas the Tank Engine and kids on the spectrum. They're fascinated by trains. They're a giant mechanical wonder, but they walk too close to the train tracks and they get struck. And so fear of danger is huge. They may echo words. So poor communication, sometimes you bridge that gap by using this. So the actual term for this is echolalia. Whether it's repeating back the exact phrase that you just heard, or actually taking a favorite phrase from a movie or a TV show and using that to bridge communication. And then we talk about inappropriate laughing. So I like to talk about, again, the law enforcement scenario. So you meet my son on the side of the road, you ask him his name. If he doesn't communicate well, you may say, hey, what's your name? And he answers right back, hey, what's your name? Well, we know we're not off to a great start to begin with, right? And then if you have inappropriate laughing, again, through nervousness or just poor communication, we've set ourselves up for disaster. So again, consider your patient whenever you're interviewing them, especially our law enforcement friends. Other clues, of course, medic alert bracelets, having a sticker in the car, and then I look at this kid here, he's got his harness that's on. So think about the wow, that word came out really bad. The societal norms that parents must overcome by placing their child in a 4-point restraint vest. So they have that on there. I like this one because it actually has a Star of Life on it. But we talked about poor body mechanics, no fear of danger, not really paying attention, not really having great communication skills. This may be the only way that that parent can take their child out into a busy setting, like out to a parade, out to a mall where there's escalators and elevated surfaces. Maybe the only way they can keep them safe. So yes, I'm going to think this kid probably has a developmental disorder, and I'm also going to be very proud that that parent felt strongly enough that they needed to keep their child safe, that they put them in a safety harness to go outside. So we talked about repetitive behaviors and how they were very, very stereotypical for the autism community. So let's talk about stimming. So stimming is any self-stimulatory behavior. So it's usually seen, again, like I said, as the stereotypic autistic thing to do. Basically, if you're awake and you're on the autism spectrum, I guarantee you are stimming some way or somehow. You may have figured out a way to really kind of minimize it so nobody saw you doing it, but I guarantee you're stimming. Have you ever tapped a pencil or chewed your nails? I think we've all done that. And guess what? You have stemmed. It made you feel better, right? It's just one of those ways that we're able to reduce our anxiety. The difference between what you would be doing as a neurotypical person is that, you know what? If you're stemming and all of a sudden your boss walks in, or you need to interact with somebody, you're probably going to stop stemming, right? Because you know it's just not the appropriate thing to do. For a child on the autism spectrum, they're probably going to stem even more because now they're even more anxious and really need that to kind of overwhelm those other sensations that are going on. What I will tell you is that if you find the way that the child likes to stem, if there's some way that you can incorporate that into your transport and care of them, it's going to make your life so much easier. So what if they tap their fingers on the side of their head, or they always like to take a plastic coat hanger and tap it on their leg? Does that really affect any of the care we're going to do? No, not really at all. But if we stop them from stemming, is it going to make their anxiety level go through the roof and maybe cause us to have a worse encounter? Absolutely. So let them stem. Now we're going to watch a quick video here to show some stemming behavior. One second. Here we go.
It's all right, Charlie. Look, there. You're welcome.
Okay, so now we're back. So in that video, we got to see that little girl, and I love that it's a little girl because usually we talk about boys being on the spectrum, and we know there are more boys diagnosed than little girls, so that's why I choose to use her. But what we saw is this little girl lining things up, and that's another stereotypic autistic behavior, is lining things up. They love things to be in order. A lot of times you'll see Hot Wheels cars lined up just in the most perfect arrangement you could ever imagine. But what we saw is that as long as things were lined up and things happened the way that she's used to having them happen, she was the most happy little girl in the world. And then as soon as mom pulled one of those things out of line, it was an instant, it was the worst thing that could ever happen to her. And then as soon as they got back in line, we saw that happiness return. So this is just demonstrating how important stemming behaviors can be to them. So find out how your patient stems and figure out a way to incorporate it if at all possible. So we talked about stemming, like I said, happens every day, all day long. The next thing we're going to talk about is meltdowns, and that may be something that you actually come in contact with these patients for. So meltdowns are the final coping mechanism for kids on the spectrum. Pretty much I've had enough of you and your stimulus and I'm done. I try to describe this and think of it as a seizure, but not in the way that we medically think of a seizure. Think of it as the way you would describe to your grandma what a seizure looks like. And let's correlate this over to meltdowns. So we know a typical seizure, a person's walking along, they have a grand mal seizure, they lay down on the ground. We have to wait till the seizure's over, right? We can't walk up to them and say, hey, you're having a seizure in the middle of a crosswalk. It's really not the greatest place to do it. Can you go lay over there in the grass? No, you have to treat them where you find them. Also, you can't walk up to them and say, hey, you're having a seizure at a really inopportune moment for me. Can you schedule this for a couple hours later, maybe whenever we get home? No. Once that seizure starts, it has to finish. And so if we think of the meltdown the exact same way, so you could be walking along, your child has a meltdown, they decide to do it in the middle of a busy church service, they do it in the middle of a crosswalk. Yes, it's going to be very difficult to do anything with them until this is over. And yes, there's going to be some things that we're going to see and that parents and caregivers do, and maybe even ourselves, to maybe limit the length of that seizure. But pretty much once it starts, it has to finish. And then whenever it gets done, the same way that we have that postictal period in seizures where you really can't talk to them and make much sense, same way after a meltdown. So the studies have actually shown that these patients drop their IQ from 15 to 20 points during a meltdown and directly afterwards. And so you're not going to be able to communicate with them too awfully well until they come back up to their baseline. So the next video, I'm going to describe to you this video, and then we're going to watch it. So I like this because it goes into the home of a family that has a child on the autism spectrum. We get to see what happens whenever he has these normal interactions, and we're going to see how the parents react. Then after we get done with the video, we're going to talk about what if we were called there for an EMS response, and we're going to talk through that and show you some little pointers and some pearls that we can bring from it. So let's get our second video started.
Hi, Joey.
Hi. Buddy.
Louis. I'm Louis.
He's Wayne. Hi, Louis.
If you could take the autism away, would you do it?
Yes. I always pray for that miracle. And one day I was in church and my daughter says, Mom, do you know that God made him that way?
So a couple of things that I wanted to bring up before we continue on the video is earlier we said that, you know what, maybe we could pick up what that this patient might be on the autism spectrum by looking at some of their interactions. So things I wanted you to take away is, how is this child dressed? So we see it looks like he's in swimming trunks. What time of the year is it? So we see a wreath on the front door. And in just a minute, we're going to see a little girl walk in a full winter coat. So we know that it's cold outside. We also saw his communication. So he started to interact with the reporter, and he had no clear communication. And as soon as the reporter said his name, he echoed it right back to him. So that echolalia that we saw. So now let's continue on.
God made him that way. So then I'm like, God made him that way to make me learn a lesson, probably. Hi, Kate. Say hi.
Carol's daughter,
Say hi.
Kate,
How was
is
school?
not autistic.
Oh, hi, kid.
You don't want to say hi? You're being shy?
That's okay.
I'm just going to bring her in. In. Down. I might call my husband in. Would you mind? Tadeo!
Okay, so now we get to see the start of the meltdown. So something changed in his routine, and that's what we believe is what started this. So I don't think anybody told his little sister there was going to be a television camera in her house whenever she got home from school. And so she became visibly scared and kind of upset. In just a moment, you're going to see her upstairs crying in her room. And I think that's what started her brother off on this. We saw that he instantly kind of stood up. He started to really need some sensory input, right? So he was making some sounds. He was hitting himself in the head. He was kind of punching the wall. He came over to his mom and was kind of swinging his arms around. But the big thing I want to point out is that he wasn't trying to hurt her. He wasn't physically trying to cause harm. He was basically, to me, saying, I need sensory input to overwhelm these sensations that are going on. And one of the key things that we see is that mom has seen this show before, you know, the same sort of way that we don't get called for every seizure in the pediatric patient that seizes, because parents are really good at that. They only call us if they've got to the end of their tricks and they need help from professionals. So we saw she guided him to the center of the room and she laid him down and got the couch cushion so he wouldn't hurt himself. And then we saw her lay on top of him, right? So heavy, deep pressure.
Hold his legs. Breathe. Go get some water today.
Oh, shall I get some water?
Thanks.
Would you like us to step out?
No, unless I let you film, and nobody's going to ever know that this is true autism. That's it. And no, but a lot of parents don't want you to see that. Breathe through your nose, Joseph. You sorry?
Sorry, yes.
Okay. Can I have a kiss?
Everything's okay now.
Everything's okay now. Oh.
Oh, we really said cheese.
Yeah, everything's okay.
Okay, so we're back. So let's talk a little bit about that video. So we got to see some classic traits that would maybe make us pick up this child's on the spectrum. We get to see a meltdown start. We got to see how the parents decided that they were going to come in and try to alleviate it, right? So use their bag of tricks. They laid him down. They applied heavy, deep pressure. Now, there were a couple of things on there that I want you to maybe think of. If I was the EMS provider who went to that call, maybe some teaching moments after the emergency. So one, would we ever lay a patient prone on the ground? No, not at all. We know that that's a big no-no, especially in this community, because they usually have a comorbidity of hypotonia. So they have a really poor muscled core, and so they don't ventilate themselves too awfully well. And then you also lay them flat and lay on top of them, could be a recipe for disaster. And then also, would you ever want to give somebody a drink of water while they're laying flat on their back? No, not either. So let's use that as a teachable moment and really make a difference there. So what I would do is talk to the parent, find out what's going on. If you're getting called, this may have went on for 20 or 30 minutes, right? So we need to say, how long does this usually last? What usually happens if we get to 20 or 30 minutes of a meltdown? We're probably going to need to transport him to the hospital. And how are we going to do that safely and effectively? So we're going to talk just a little bit about maybe using some medications, because should we really be wrestling anybody in 2019 in EMS? No, not at all. So let's jump back to our presentation. So let's add some tools. So de-escalation techniques, things that we can use and talk about this. So if we know that we're responding to this emergency that we just watched, let's go ahead and shut off our lights and sirens. Adding more sensory to this is definitely not going to be helpful. We know that the behavior is not harming anybody or themselves. Let's let it run its course, right? So that's what we saw mom doing, getting him to a safe area and letting this thing fizzle out. And we saw she was able to take care of this herself. And after he was able to be calmed down, talked to, got some heavy, deep pressure, everything was over, right? He kind of reset, went on his merry way. And so hopefully we can make that happen. Guide them to a safe area, right? And then remember, you being calm and instilling confidence and calmness in your peers is definitely going to make this entire scene be more calm. Try to have one person be the speaker for the group. So again, if this child has limited communication abilities, both receptive and expressive, if you have multiple people talking to them, I know I get confused whenever 2 or 3 people try to talk to me. So try to have one single person be the speaker, and that should probably be the best person who deals with your behavioral health calls on the ambulance. Also, have somebody talk to the family member too. Let them know exactly your plan. If you do decide to use a medication for any of its sedation usages, make sure you explain to them exactly how long it takes for the medication to come on board, what the onset is, how long it's probably going to last, and what this realistically is going to look like so that you can safely transport them to the hospital. Try to reduce the number of people in the area. Again, you don't need extra folks, so just let them know that you've got this under control, and maybe even let the rest of your rescue squad stand outside. This is something you can probably handle by yourself, at least to get that initial understanding of what's going on and seeing if you need 5, 6, 7, or 8 people to walk into that house. And then just try to calmly let everybody know that you're not going to cause any harm to anybody and you're just here to help. And then, of course, we said, again, never place them prone. So there are no specific medications that are contraindicated in the use for sedation for kids on the autism spectrum. There's not a ton of medications that they take specifically for it, and none of them interact with any of the common sedation medications, but definitely consult with your local medical direction to have guidance for that. So some medical considerations, of course, we want to keep our eye out for neglect, but we try not to jump to conclusions. So these houses are going to look different than a neurotypical house. You're going to see locks on doors that you're not used to. So locks on bathroom doors, on pantries, because these kids notoriously don't sleep at night. And so they like to get up and wander while mom and dad have finally fell asleep exhausted. And maybe the only way that parent can keep their child from drinking so much water that they become hyponatremic is to put a padlock on the bathroom door. But again, remember, you are a mandatory reporter, and if you see anything that kind of makes your spidey sense go off, please don't hesitate to phone call. Let that expert make that final decision. Remember that 30 to 40% of these patients will have some sort of a seizure history. And then weird ingestions. We said these patients have sensory systems that maybe don't work as the same way that a neurotypical child's sensory system would. So it allows them to ingest some things that we would think a child just wouldn't. So I remember a couple of children I've had on the autism spectrum over the years. I had one that ate a bunch of cigarette butts. And then a friend of mine's child actually ate a couple of pounds of pea gravel off of the playground and came to the hospital for abdominal pain, and sure enough needed emergency surgery to remove all of that gravel in her stomach. So my rule of thumb is that if a parent or a caregiver believes their child has ingested something, even if you think there's no way possible that would happen, let the hospital prove them wrong, because there's a pretty good chance that they actually did. Take your time with exams. So go distal to proximal and check them carefully for injuries. Remember that high pain tolerance whenever you're doing your assessments, and treat them judiciously the same way you treat a neurotypical kid. Try to involve caregivers in your exam and treatment. Yes, a caregiver is never going to be able to take your stethoscope and diagnose an S2 gallop, but they can probably push around on their stomach and see if the patient winces in pain. They can check out their extremities, and they're going to be much more comfortable with that caregiver. Also, I say for all my EMS provider friends, check your policies, figure out a way to have that caregiver ride in the back of the ambulance with you. It's going to make your transport much more calm and much more safe by having that person that autistic child is comfortable with. Try to demonstrate if you're going to do any procedures, and maybe even something as simple as taking a blood pressure, demonstrate on a parent, or I always like to say on those students that do their ride-alongs with us, and show them that this is going to be fine and you're not going to hurt them. Use all your special items that you have available to you, whether that's a teddy bear, a fireman's helmet, and guess what? There's no age limit on that stuff. So if you have an adult that's has a developmental disability, the worst thing they can say is no if you ask them if they want a fireman's helmet or a teddy bear, but that may be the thing that they really need in order for them to get through this emergency with you. Once you get to the emergency room, your job has not ended. We need to make sure we do everything we can to try to get them through the emergency room as quickly as possible. Yes, they may not be the patient that requires the most resources and be the most sick, but I guarantee that that child is going to eat up more resources in the emergency room if we don't get them in and out quickly. That's going to be the patient who's in one of the rooms yelling and screaming and banging on the walls, all because they have an ear infection, because we haven't got them in and out quickly. And I guarantee that's going to clog everything up. So remind every person, this kid's on the spectrum and they need a little extra TLC. This really stems from, we know that hospitals have to be torture for people with sensory problems. The sheets are scratchy. I don't think anybody's ever taken a normal bowel movement in an emergency room. It's just weird. It's overload. So get them in and out quickly and make everybody a little bit happier. So elopement. So very, very common call for this population. You know, we said that these need to be a priority call, mainly because they may not know that they're lost. So a neurotypical child, if they get lost, within a couple of minutes, they're going to figure out that they're lost. So one, they're going to attempt to go to a place that they can become unlost, if that's even a word, but they're going to attempt to find a rescuer, right? For a child on the spectrum, they may not have any idea that they're lost at all. They may not know their name and they may not respond to it. So can you imagine how hard it will be to find somebody who doesn't know that they're lost, so there's no sense of concern, and then they also don't respond whenever you call their name in the woods. So we have to make these priority calls. So normally whenever a child goes missing, they'll usually send a fire truck and a police car to go look for them, and then they kind of look for them for a while, then they decide, wow, this kid is actually lost. We probably need to call more help. What I say is that if you go onto one of these calls and you find out, even through the initial dispatch, this child has a developmental disability, you need to call all the resources you possibly can early, because if you have a chance of finding them alive and finding them non-injured, it's going to be soon and quick. So make it a priority. We know this group is also just a prime target for abduction and abuse. We said that they have really no fear of danger. They have poor communication skills. They don't know that they're lost. And so this is actually the biggest fear that I have for my son is he's a genius, but I tell you what, if you show him your iPhone, actually he's an Android guy, you show him your Android phone and let him play with it, he will get in your car all day long and he'll be gone instantly. So a huge target for abduction and abuse. And then we also know that one thing that can make it a little bit easier for us as first responders to find them is they're not usually randomly lost. They're usually seeking out a favorite place. So whenever you interact with the parent, say, hey, where does your child like to go? Well, you know what? He really loves windmills. Oh yeah, there happens to be a windmill a couple of miles away at Farmer Johnson's field. Let's go over and look out there. There's also two other things that we talk about is they like to seek out water. So unfortunately, most of these kids don't know how to swim. So, but we know water is, you know, soothing. It sounds good. It looks good. So these kids are attracted to it. So whenever you arrive on the scene, know that these are going to be first places that you need to check. And it doesn't have to be a big body of water. It can simply be a fish pond in somebody's yard. So use your knowledge of your still alarm area to know where the water sources are and check those out quickly. Also, we need to try to encourage the use of ID jewelry and to pre-plan. Some things that we're starting to see is that parents are starting to use temporary tattoos, especially whenever their kid's going to be outside playing. So I think of them going to Six Flags, a water park, a county fair. They may actually use a temporary tattoo and place that on them that says, I have autism and my mom's phone number is this. And so check them for a temporary tattoo. We just might see that. So talking about fire rescue. So I don't claim to be an expert in fire rescue. I did do my time in the volunteer fire service, which I think a lot of us did. And then I did have the opportunity to work for more than a decade side by side with some great career firemen. And they taught me a lot of stuff, and I did a lot of research on my own. So one of the things I need to point out is that forced entry may be needed inside. You know, typically you show up to a house fire, you take your Halligan tool with you, you bust down the front door, you drop your tools, and you walk inside because you're not looking for big, heavy locks and doors that you're not ready for. But we said earlier that these houses may look just a little bit different, right? There may be heavy doors, heavy locks inside. Also, you may live in a community that you may not see bars on windows because you're a low crime area. There may be bars on windows for this house, not to keep people from getting in, but keeping that kid from getting out. So take your tools with you. You may need them to rescue yourself or that child. Also try to pre-plan. So just like you pre-plan a commercial structure to make sure you know how to not only save the property, but get your firefighters in and out of it safely, we want to do the same things for people on the developmental disability spectrum, right? So if you know these folks are in your area, drop by one day in the engine, take a look at their house, ask them if they have any of those big doors and big locks that you need to know about, and pre-plan that house the same way you would a commercial structure, because there's a high likelihood that you'll need that information in the future. And then remember that adults with autism may hide exactly like a child. So we know kids like to hide under beds and in closets and those places. Adults on the spectrum may be in those same areas, so check them out as well. If you need to move that person quickly, you know, from a dangerous situation, whether it's a fire or I think about a vehicle accident on the interstate, use a blanket, or I would even say take off your turnout coat, wrap that person up and physically remove them from danger. Probably the biggest thing that I like to point out is really be mindful of the bolt risk. So we said earlier, poor communication, but the biggest thing is no real fear of danger. So the way this plays out, and what I really need us to be working on is, you go to a house fire, you rescue the child that's on the autism spectrum, you bring them out, you set them on the curb, you go back to doing fire operations, and if nobody watches that kid can simply stand up and walk right back into the house, because you know what? That's where their Pokemon cards are. Or the other thing is, I'm really, really stressed out, and whenever I get really, really stressed out, I like to go to my room. Well, they may walk right back into their room. So we say there's no way this could happen, but I guarantee you, if you look at the literature, especially in the fire service, you'll find examples of this. And we actually had a case example of this in St. Louis several years ago, where they rescued the child, they put him on the curb, they went back to operations, he walked back into the house, they rescued him a second time, they brought him back to the curb, he went back into the house, they rescued him 3 times. You should never have to rescue a patient more than once, because we know that each successive rescue attempt becomes more and more risky. So kind of a rule of mine as an EMS supervisor would be to, if a patient on the spectrum comes out of a dangerous situation, I want them completely off my scene, because even in the back of an ambulance, we know that we get to doing other things and ambulance doors don't always lock, and that child could definitely elope from there and get right back into danger. So I want to find a way to remove them from any possible danger from that scene. And then, of course, anytime you're doing anything from an elevated platform, remember, poor body mechanics, poor communication, tie yourself and them in before using a ladder. In conclusion, remember that kids on the autism spectrum are going to be our patients regardless of where you practice. We know that preparation will make this a positive encounter for both you and for them. Remember, a lot of the times they do not have control over their behaviors, and they're not being bad kids. Take your time and go slowly. And then I always like to sum up, and this kind of stems into all of our kids that have any sort of medical issues, especially all the wonderful stars kids that we deal with these days. You know what? Yes, this call is not the easy call that we all like to run, where we go out, we don't even really have to wake up. We can run that call in our sleep, we can write our report, and we go back to bed. Yes, these calls are going to take more time, right? We've got to think a little bit more about them. We've got to use some more skills that we didn't think we were going to be using. We may have to be creative in our treatment and our transport options, but you know what? At the end of that call, we get to come back to the station, we get to write our report, we go back to bed. Remember, for these families, whether it's a child on the autism spectrum, it's a child on a ventilator, a child with a congenital heart defect, or any of the other, myriad of conditions that we see these days, at the end of that call, that patient and that family still has to deal with all of those issues. So if there's anything that we can do to be a little bit more empathetic, a little bit more sympathetic, and figure out some way to make this a great encounter for them, just remember it's always worse for them. So do what you can, make me proud. I know that you can do it, and I'm super excited for you to have this information and put it into your tool belt. So thank you very much. Remember, you guys will get a survey in a couple of hours, and then eventually you'll get your CEU certificates. Have a wonderful day and be safe out there.